Okay. So I'm going to share my screen when I figure out, yep, okay. So you know this case pretty well. So it's probably, so a lot of it's going to be, okay. I'm still trying to get over that other patient from last week at the moment.
Yes.
Okay, so yeah, so this is this is really quite interesting because this is quite a severe class 3 patient. Okay,
Yes.
and there's no doubt. When you first saw it, did he go off to any other orthodontist prior to seeing you? Have I lost you, Beck?
With this guy's actually, hello, can you hear me?
Yeah, you're cutting out.
Yeah, I think my internet connection is somehow not very stable, I'm afraid.
Okay.
Yeah, no, he hasn't gone to another specialist or anything like that. He's a little bit of a funny. So as you're aware, I live in Ballarat, and so he's one of those patients that comes to me, but he actually speaks to me in Mandarin.
Oh, right. Do you speak Mandarin?
So there's a little bit of that language barrier. Yes, reasonably. Not that fluent, but yeah, enough. Yeah.
Put it this way, a lot better than myself.
So basically he never went to another second opinion or anything like that.
Okay.
But one of the things that he said to me straight away was that he wasn't interested in surgery.
Okay, so he's probably, he looked deep down, I think, if he says that, he's probably seen somebody else. I'd be surprised.
Maybe.
It's pretty rare for a patient to come up with, everybody thinks that they don't need surgery as a patient. So I would, in the back of my, somebody would have mentioned the word surgery term later on.
Possibly, yeah.
In the past. But I can guarantee if he had gone to 20 orthodontists, 19 of them would have said surgery. Yeah, they would not have touched him otherwise. Okay, so severe class 3, and as we said, actually, I just want to see who else is online. Robin's online. Okay, so I'm not going to ask her any questions. Okay,
hi, Robin.
She's coming into work today, so she had the day off yesterday, so she's got days. So the key to all class 3s, the first key is, as we keep talking about all the time, is can we get them edge to edge? Can we get them in centric relation? Okay, so, and this is exactly what you've done. You've got them in a centric relation position, okay, edge to edge. Okay, I'll see.
Yes.
Good morning, Bobby. And so then at that point, you say to yourself, in this class 3, can I move those upper teeth forwards a little bit? Can I move the lower teeth back a little bit? Now, the problem you've got in this particular case, what's your problem?
There's nothing to move back for them.
No, nothing can move back. Taking out a lower incisor would be a bit of a disaster because those lower anteriors will retrocline even further.
Yes.
Taking out lower premolars would even be worse because you've now got more space and they're going to retrocline even further. So you are now committed to purely upper arch treatment. If you went ahead and did lower arch therapy here, the lower incisors would procline even further, and you would actually make the reverse overjet worse. And that's what we would do if that patient was. We'll talk about that in one of the other modules. If you were preparing a patient for orthodontic surgery, you actually make them worse before you make them better.
Oh, okay.
Because what you're doing in orthodontic surgery is, at the moment, you've got what we call dental compensations. The lower teeth are compensating for the class 3. And so whenever you do a surgical case, you want to remove the dental compensations.
Yeah.
So, for example, that patient who's a class 2 and the upper incisors are very retroclined, what do we have to do? We've got to move those teeth forwards.
Yes.
So if they've had inadvertent extractions of upper teeth, we might have to open up the spaces in some of those cases to get enough expandable forwards, and vice versa. And one of the biggest problems with class 3 patients when you do surgery is to tell them they're going to look much worse So for 18 months, their reverse overjet's going to get worse and worse. And then it's going to be fixed up with surgery. So that's an issue when you're talking about surgery. So here we are. Here we are. We're edge to edge. So now what we've got to do is move these upper teeth forwards, which is actually quite a big ask, because we're going to have to procline and advance these teeth quite a bit. If these lower anteriors were slightly proclined or advanced, we could then move the lower teeth back a little bit as well. You've got to do all of this in the upper arch, unfortunately.
Yeah.
Okay, which makes it in one way more difficult for you. Okay. Okay, so this. Okay, you've got a deep curve of speed which you're not going to correct if you don't do surgery, because you can't put the biggest mistake people make is they put upper and lower braces on and they're chasing themselves all the time, and they're actually making it into a surgical case. Okay. The last thing you want to do in a class 3 is take out any upper teeth, obviously.
Of course, yeah.
Okay, because let's say you've got that blocked out upper right lateral, and you take out some teeth, you're going to make the reverse overjet worse. But that is a technique that we use pre-surgically. So if we were doing surgery, I would have no problems taking out the upper fours, moving the teeth back, making the overjet worse, and then we get the surgeon to move the maxilla forwards or the mandible backwards.
What's the reason you would try to make it worse? Why wouldn't you just, because there's no other way, you need to fit it all in and then you have to have surgery?
Yes.
Is that right? Because if you didn't take the tooth out, then basically it's wanting to go forward. You can't actually straighten the teeth because there's restriction. Yeah,
because if those upper teeth come forwards, you're actually now making another dental compensation. And the whole idea with surgery is you've got to think of if you're doing surgery, you look at the upper jaw as a separate entity to the lower jaw. So I want my upper teeth to be perfectly aligned with the upper jaw in the right angulation.
Yes.
Okay. So if those upper incisors were proclined, I'd take out upper teeth. But I would then retract the upper teeth and then move the whole upper jaw forwards or the lower jaw back.
Yeah.
And this is the funny part.
Okay.
You've got a Ceph here, right? And I've heard, and I've actually been involved with cases from oral surgeons and from the orthodontic department in my very early years where they looked at this Ceph and they go, "That's a class 3." But it's obviously a class 3 because you've got that incentric occlusion. And what it should actually have, they should have 2 Cephs, one in this position, okay, and another in centric relation, because this position is going to show you the vertical factor to it. Because if you've got the patient in centric relation, edge to edge bite, it's a different vertical. Does that make sense?
Yeah.
So when you do class 3.
So how do you put them in centric occlusion? Yeah.
How do you put them in centric relation? You mean? Centric occlusion is this position, which is easy, where the patient bites together in full contact. Centric relation is the initial contact position.
Yes.
So what you do is you get a very thick wax bite, okay? So it's only when they just before they contact on the upper incisors, that would be your wax bite, okay? And you would give the wax bite to the patient, and they would tell the radiographer to take 2 X-rays, one where they're fully closed, and the other one with the wax bite in place. Does that make sense?
Yeah.
Okay. And every orthodontist just does a one Ceph, which is diagnostically incorrect. Because every patient is going to look class 3, and when you do the numbers, they will be class 3, obviously. And I've seen patients, and I've treated them where there's been a 10 millimetre reverse overjet, and we've treated them non-surgically because we can get the upper and lower incisors edge to edge. So don't be scared by the amount of reverse overtake. It's a question of, can you get them edge to edge? With the caveat though, that they're not severely, the uppers aren't severely proclined and the lowers aren't severely retroclined in an attempt to compensate. In other words, if they're really severely proclined, you might not be able to procline them any further. The uppers.
Yes.
If they're severely retroclined, you may not be able to compensate them any further.
Yes.
Okay, so that's the caveat on that. Okay. So the best cases are those where the upper incisors are upright, okay, which these are a little bit upright, okay, a little bit, and the lower incisors are a bit proclined. They're the best cases because it's easy then to compensate them a little bit further. And then, if that was the case, we could have done upper and lower braces on them. And then you would be in a much better situation. Does that make sense? Or have I lost you?
Yes.
Have I lost you?
Yeah.
So there are different.
Hello.
Yep.
Yes, that makes sense.
Okay.
Hello.
Yep. The other.
No, I can.
Sorry, Vic.
Yeah, I can still hear you. I think my connection's really poor. Sorry.
Yeah. No, that's all right. Not a problem at all. So this is before. So these are your photos before and after. Okay.
Yes.
You don't see a great deal of change here. Okay. Right. Except for. Okay. So a class 3 deep bite is a much easier case than a class 3 open bite. Okay. Because what are you going to do? As you open the bite, as you open the vertical, what's going to happen to the mandible?
The mandible will, as I open the vertical, mandible,
will rotate backwards.
Rotate backwards, yeah.
And that will help the class 3 situation.
Yeah.
Okay, so a class 3 deep bite is a better case. If you had a class 3 with an open bite, right, then as you open to try and correct the class 3 to bring the mandible backwards further, right, the open bite's going to get worse.
Yes, of course.
Okay, so class 3 deep bite, you can look like a genius. Okay, and so when you look at his facial profile, you can already see his vertical has increased because you've opened up his bite. Okay, so his lower facial height has already increased, which is exactly what we expect.
Yeah.
Now the other part, which is really interesting, look at the improvement in his profile already.
Yes.
Because he was overclosed.
Yeah.
Okay, so now can you imagine if you took the Ceph in that position?
Yes.
It's a totally different Ceph to the one here.
Yeah.
And how long was that? That was what?
6 months.
6 months.
Well, 5.5. Yeah.
From there to there.
Yeah.
Okay. So he already looks better now. Okay.
Yes.
He already looks better, from a facial point of view. Now the other question. Now this is your question here. Okay. How do we go ahead and get these teeth better? Okay. Because from an alignment point of view, he's not looking too bad. Okay. He's not looking too bad. And to be honest, now, why do you think the teeth aren't fitting together properly? When you look at that, so let's just go back a stage. This is one of the big reasons why orthodontists like to do upper and lower treatment always. Because if we had lower braces on, if we did, okay, we would run some vertical elastics here.
Yeah.
And we would close him up. Or we would extrude those posterior teeth with the brackets.
Yeah.
Because he's got a deep curve of speed. And so, so this is your problem when you're just doing one arch treatment. Okay? And also the transverse issue and that's what we were talking about with palate expansion. Whenever you've got a transverse problem, the way you're going to correct it is by coordinating the arch forms, which requires upper and lower treatment.
Yeah.
So once again, all these transverse issues that you're talking about would be corrected if you had lower brackets on.
Yeah.
Okay. So now we've got to do that, and once again, it comes down to managing everybody's expectations. The first thing is to manage everybody's expectations. Okay.
Yes.
And to me, I would have said to this patient, you know what, we've stopped you from having surgery. You look better, and we'll give it time for those teeth to super erupt, which they probably would, in all honesty. Okay.
Yeah.
But
So, because I had bite turbos on there, and literally it was just before I took these photos that I took them off, because I was like, right, they've gone over the finishing line for now.
Perfect.
So I've taken them off.
Where were your bite turbos? Were they on the 6th?
They were on the 6th.
So you probably have got some extrusion of the 6s, some intrusion of the 6s. Intrusion,
that's what I thought.
Yeah, which should actually improve now. Yeah, there should be some bounce back. Okay. But let's look at other options that we've got. So we can let nature take its course. Okay, so that's one option. Okay, the key here is you don't have much overjet, so I still wouldn't go ahead and put a full lower brackets on, because there's a minimal overbite as well now. So if I put full lower brackets on, I've got a chance that as I extrude those posterior teeth, I'll also get some more intrusion of the anteriors, and I might end up with too little an overbite.
Yes.
Okay. So what else could you do here?
Gosh. To be honest, I have no clue. I don't really know, because I was like, initially I was like, do I just let nature take its course, and I'm like, how predictable is that? Like,
well, that's the issue. Yeah, that's the issue. Personally, my practice, that's what I would be doing, unless this okay. And is the patient complaining at all or not?
He's not. No, but he doesn't say very much when he comes in anyway. So
okay. The other option is you could put some little buttons on. Yeah. Okay. On these posterior teeth, and just run some elastics.
Okay.
Yeah, but now we're going to ask the next question: where would you put the buttons?
Well, quite gingival. Is that on the butt? Actually.
The problem is if you put them on, and you're going to learn this in module 2 more, Beck. Okay.
Yeah.
If you put them on the buckle, and you're running posterior box elastics. There'll be a tendency for the uppers to roll inwards. Okay.
Yes.
Which is good, because that's what you want here. Okay. But you're also going to have a tendency for the lowers to roll in
out. To go outwards towards buckle?
No, towards the lingual.
Towards the lingual as well.
Yeah, because you're pulling, you're extruding, and you're a buckle to the centre of resistance of that tooth. So
okay, so I'm putting a button on the buckle, and I'm running it to the lower tooth, and then I'm attaching it to the bracket.
Yep.
On the upper tooth.
Yep. Yeah. If you did that, okay? If you did that, so you've got an extrusive force on your upper arch. Yes. You've got an extrusive force which is buckled to the centre of resistance of the tooth. That tooth's going to roll in lingually.
Okay. Yes. You're right.
If you've got a buckle force, if you've got extrusive force on the lower arch, buckled to the centre of resistance, they're going to roll in lingually.
Yes, that's correct.
Okay. Yeah. Not what you want. So what else could you do then? If you
I could put a button on the. Hang on, I'm just thinking.
Yeah.
If I put a button on the palatal of the upper, and then a button on the buckle of the lower.
No, well, but you're getting close, but no. Okay.
Oh, okay.
You want your upper buckle segments to roll in lingually.
Oh, I do want them rolling in. Okay. Oh, then in that case, I would put a button on the lingual
of the lower
and run it through the upper bracket on the buckle.
Exactly. So it'd be like a bit of a cross arch.
Yeah.
And so now you're going to roll the uppers in, and you're going to move the lowers buckling.
Okay.
Okay. They're very hard elastics for the patient to wear, but because you've got no wires in there on the lower, they'll be bloody quick if he wears it. It'll be very quick.
Yes. Yeah.
because there's no constraint in the system here.
And in this case, what I do, I would need to do it on every tooth that I'm trying to close the bite for, don't I? So on the molar, the premolar.
Yeah, so that's the other part to it. I wouldn't be doing it on that lower right 4 because you're already in contact on that lower right 4. I would do it on the lower right 6 and the lower right 5.
Yes.
And I would do it on the lower left 4, 5, and 6.
Okay.
And they'd be run like in a. So you don't need 3 different elastics. You just have one elastic that will attach underneath all the buttons on the lingual of the lower left, and they will go through. And they will go through the occlusion to the upper.
Okay. I don't really know much about elastics at the moment.
Exactly right. But we're going to teach you all that in module 2.
Okay.
And we're going to teach you all the biomechanics that go with it, because once you understand all of that stuff, it's like MacGyver. You will figure out, and you will figure out a way to resolve all these issues when they come up.
Yeah. Okay.
And that's what but my aim in all of this, Beck, is with every situation to give you hopefully about 6 different ways of treating a problem.
Yeah.
Because one that makes it more fun, but you once you understand what you're trying to achieve, it's really very easy. Personally, I wouldn't do anything. I'd just leave it because I think it's just going to erupt on its own accord over time.
How long will it take for it to come to erupt on its own? Like 3 months or something?
How long's a piece of string?
Oh, that's true.
But,
so you just finish the case basically, and then that's it.
Yeah, but I would be hoping about 3 months.
Okay.
But you just don't know. There are people who would argue that, because I've seen it happen where those posterior open bites don't close. Okay, and people would argue sometimes some patients can have a lateral tongue thrust, so the tongue gets in between laterally.
Okay.
The bigger the posterior open bite, the more likely you can have a lateral tongue thrust appear. So I think it's unlikely in a case like this where it's pretty minimal.
Yeah.
Okay, but if you wanted to close it up, use the elastics, and that will also help the transverse issue that you're talking about.
Yeah.
You get some constriction of the upper buccal segments and some expansion of the lower buccal segments.
Yeah.
So that's both problems that you're talking about.
I do have a question for you, which is not so much related to the posterior open bite, but it's to do with the 1-2. Every time I look at the 1-2, I'm just like, I don't know what's going on with that tooth. Like, okay, so firstly, I know that those lateral incisors are really oddly shaped. They're almost like canines.
Yep.
But the thing is, yes, when I take the photo, I can see that it's in alignment. It all looks fine. But from the buccal perspective, it just looks really weird. Like it's just not in the right position.
You're totally correct. Okay, so this is where you're at now. So have a look at from the palatal aspect, right? Because this is how you can see if it's a talking issue. Okay, see how I can if I look at the centrals, I can see about the same amount of crown when I look at it from the occlusal point of view. Okay, but when I look at the laterals, I see far more crown than I do centrals. Okay.
Yeah.
So if I run my eye all the way around here, the posterior teeth look pretty good. Okay. Okay. This upper left 6, I'm seeing more crown, so that probably could talk out a little bit more, that upper left 6, but that's all right. So this is more of a talking issue that the roots are too far palatal. So let's go to the original photos and look where the roots started off with. So when I'm using round wire or even a URA, whatever I'm doing, all I'm doing is pushing the crown out and the root is staying behind.
Yeah.
So from day one, this was a talking issue.
Okay.
So once again, in our module 2, what we're going to do is show you how to fix up these talking issues, because an upper left lateral incisor bracket normally has about 7 degrees of torque in it, which is lingual root torque or labial crown torque.
Yeah.
Okay? That's the norm. But what we want here is we want labial root torque. From where we started, we actually want labial root torque.
Yes, yeah. Mm-hmm.
What we would do here in our OrthoED program, the day one. Well, did you bond brackets on that tooth day one, or did we put an open coil in?
Oh, that's a good question. I think it was an open coil.
It would have been an open coil. So what I should have got you to do is to bond that lateral incisor bracket upside down. So when you bond it upside down, you change the torque. So instead of 7 degrees of lingual root torque, you get 7 degrees of labial root torque.
Okay.
Okay. Yeah. And you can still do that. Okay. You can take the bracket off, bond them upside down. You don't change the tip. When you bond a bracket upside down, the tip stays the same. Okay.
Yeah.
When if you move brackets from one side to the other, you know, like we would be doing on that impacted canine case, that changes the tip of the teeth.
Yeah.
But it doesn't change the torque unless you turn it upside down.
Okay.
Okay. So what you could do here is you could put that bracket on upside down. Okay.
Yeah.
If you do, what wide are you having? 20 squared?
What does it say at the very bottom? Because it says, what have I got? 20 by 20. Yeah, 20 squared. That's right.
Yeah. And the 20 squared, because you would have to twist that wire in a lot more, that'll start to give you that root torque. So you can only get the real torquing issues, the real torquing with a rectangular wire. And we'll go through that in module 2 in more detail.
Okay.
Okay. But yeah, because you're 100% right. You look at that lateral and it's flared out. It's compensating again. And the problem here, and I would recommend that you take that bracket off, you turn it upside down.
Yeah.
Because from a stability point of view, teeth always want to move back to where their root is.
Yes.
Okay. And this is why when we do lower incisor extractions, we want the treatment of choice is the one where the root's the furthest away. That's what takes the time to move, is to move a root.
Yeah.
Okay. Do you remember, did you ever do any URAs to correct anterior crossbites?
No, I haven't. No.
Yeah, we got taught that if you do a URA and you move the tooth up, like a lateral incisor and crossbite, you move it over the bite, it's going to actually, because of the overbite, it won't relapse back. But that's not true, because most patients are in a rest position. So they're not actually always in occlusion, obviously. On where the root was initially will depend on where it's going to move back to.
Yeah.
So this is a case that, yes, I would like to go ahead and improve the root a bit more.
Okay. Yeah.
But that was well spotted. But the best way is you get your big mirror, like you do your photography mirror.
Yes.
Okay? And you can just have a look, and then it becomes pretty obvious that there's that root of that lateral needs to move labially.
Yes. Yeah.
And the left lateral needs a little bit more, but not as much as the right lateral.
So do you think I should do it for both the 1-2 and the 2-2 then?
Let's have a look at where you were. So the 2-2 doesn't look too bad clinically.
Yeah.
I would probably just do it for the 1-2, honestly.
Yeah. That's always been a funny one.
Yeah, because there is an argument here, and it may have been a good argument from day one when you with that patient, because of the shape of these teeth. At the end of treatment, you're going to need some veneers. Yeah, and then you could have got and that 2-2 can be fixed up very nicely with just a veneer.
Yeah,
cosmetically, he's obviously worn these teeth, because of his initial occlusal scheme.
How do you think that was worn though? I just thought he was born like that.
No, see, I think what happened is that he's always been.
It's like a shearing force on the.
Yeah. Like at some stage he would have been hitting on the lateral before his mandible grew a bit.
Yeah.
And he's been just wearing away his teeth. Yeah. And if you think about it, if you think about it here, okay, when he goes into lateral excursion, and this is Robin's problem too. They go into lateral excursions. What do you think is going to hit?
Oh, the laterals.
Yeah.
Yeah.
So if he's got a bruxism habit, which most people do at night,
Mm,
he's going to be having constant wear of those teeth because he's got no protective guidance.
mm. Yeah, that makes sense.
Yeah, too many people just look at these cases from a static occlusal point of view.
Yeah.
But yeah, but you've got to also look at this from a lateral functional point of view as well,
Mm.
because that's where you're going to pick up. Yeah, you can see he's going to be wearing away that upper right lateral all the time.
Yes. Yeah, you're correct. Yeah. Mm-hmm.
Hey, Dick, I've never been wrong.
No. No.
I do say that tongue in cheek, okay? But think, you got to go back, go back a bit, and there's minor issues with this case. But remember, the first premise I said, 19 out of 20 orthodontists would have done orthodontic surgery for this guy, right?
Yeah.
Okay. You've treated him in 6 months. You've taken him from a very poor facial profile, okay, to a significantly improved frontal view, okay. But he may not realise that. But from the lateral perspective, he looks 100 times better.
Yes. Yeah.
His occlusion's better. He's even here. He's not going to have any issues. I mean, you can I'm just thinking whether you even extrude his upper left canine as well. So you bring them down to get some canine guidance here.
So in this particular case, you're thinking I should put a lingual button on the
lower four.
On the lower 4.
Yep.
And run. So why wouldn't you run it from the lower 3?
Well, theoretically you could. But I just don't see the point of. I don't know whether you want to extrude that lower canine very much. If you look at it because remember you're going to have an extrusive force on these teeth as well. So if you have a look at the height of that lower left canine, that doesn't look too bad compared to the lower left dental.
Yeah.
So I think, and what I'm concerned about is if this tooth extrudes, you might start getting an interference.
I see. Yeah.
I think just to be on the safe side, you can run it from the lingual of the lower left 4, lower left 5, lower left 6, up to the buckle of that lower canine around.
Yeah.
Okay.
So just going back though, sorry, because my understanding of elastics is not that great. Yep. What size elastics am I looking at using?
Okay, perfect. I'll just see if Robin's still on the line. Robin, are you still online? Or are you on your way to work? I can't, for some reason, I can't get it. We call them Fox elastics. I wouldn't even have a clue what size. Every company uses different elastics, and I just say Fox elastics. Okay, Robin knows the exact size, and because every company has different elastic names for them. Yeah. So if you email Robin,
I'll probably email her. Yeah, that's fine.
Email Robin, and she will give you the size of Fox elastics.
Okay. And so my other question is, okay, so I'm running these elastics, but not all of them have the space for the elastics, if that makes any sense. Like I could see, like, for example, here in the pictures that the bracket on the 3s, for example, you can definitely run elastics and you have an attachment. But then on those posterior teeth, other than the like the upper 6, which obviously has the 2, that one you can run elastic. The other 2, so the other premolars, they don't actually have an attachment.
No, so what you can do, but you won't need to, but you can actually tie what we call Kobayashi ties. So they're like ligatures, okay, but they've got a little hook. So you can take off the elastic, tie like a ligature, but it's got a little hook on there. But in all honesty, the elastic will sit underneath those brackets.
What's it called again? Sorry.
Kobayashi tie. Koby. We just call them Kobe ties. But you won't need them because even if it's not sitting right underneath the bracket, okay, it's still got a vertical force. It's still got a vertical force on all of those posterior teeth.
Okay, so you're saying they can just run them to the tube.
Yep. So it'll probably sit just above the bracket onto that tube. So the the whole segment will have a vertical force on it.
So, okay, so if I put on, say, on each side on the posterior, I have lingual buttons. Sorry,
Yep.
this might be a silly question, but I have a elastic that's running from the lingual of those to the tube. Does that mean that on the single tube I've got like more than one elastic on there?
No, you're just going to have one elastic.
Oh, just one elastic.
So it's going to stretch all the way across from the lingual of the lowest 5, 4. Okay.
Yeah.
Then it's going to go up to the 3, 4, 5, 6. So it'll be like a trapezoid.
It's not really making sense to me now. Sorry. Okay. So you're saying the elastic is going to stretch between. No, that doesn't make sense either.
What I might do, I might get Robin to see if she can draw
a diagram for me.
Yeah. Can I draw a diagram here? I don't know whether. Oh, hold a sec. Annotate. Okay. I may be able to draw. Okay. Let me see if I can. Okay. 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 So it goes from the inside to it goes to the inside here. Okay. But they're the lingual. They're on the lingual.
Yep.
And then it'll go round to there.
Oh, okay.
Okay. Okay. So there'll be a vertical. So that it'll be going through the occlusion.
I get it now. Yeah.
Okay.
Okay.
Okay. Robin's just told you what they. She's a good girl. I don't understand, darling. Why aren't you on your way to work? Okay. So it's 1/4 inch, 1/4 inch, 3.5 ounce elastics.
Yeah. 3.5 ounce. Okay.
Yeah. 1/4 inch, 3.5 ounce elastics. That's what we use. Okay. And they change them every day. So you give them packets of them.
Yeah.
Okay.
So they change them once every day, did you say?
Yeah. So we give them packet because they lose their stretch after about a day. They take them off to heat between them. So Robin teaches you that response while she's at a red light.
Yeah.
Yeah. So on this side here, they would go on the inside, but I would only do it on the 5 and the 4 because on the 5 and the 6 because the 4's already in contact with that canine.
Yeah.
Okay. And then it will go up.
Yeah.
Okay.
Yeah. Okay, that makes sense. Yeah.
So they're going to be hard elastics for the patient to get on, but it should be very quick, the movement. So make sure you see them every 3 weeks because the last thing you want to do is to over extrude these teeth, bring them in hyper occlusion, and a posterior and an open bite develops. So you want to keep it so it's just touching. Don't overdo it because I'm worried about the minimal overbite anteriorly. So just get it a lot closer, and then and then we're going to.
Oh, okay. So just touching, and then you stop, and that's it.
Yeah. Well, what you can do is at that point you can just wear them just at night time, just to maintain it for a month or 2, so it doesn't bounce back. So because you're going to have full time wear, then wean them off just to night time wear so it doesn't bounce back. Okay, and but don't keep going full time.
As in, once you get them very close, stop wearing them full time, wear them at night time. Okay. And at which point do I say, okay, well, this is now it? Because you can see literally there's contact on.
Yeah, very, very, very gentle, light contact.
Yeah. Okay. Why would you wear them at night time, though? Because at night time, you're not really opening your mouth. Oh, actually, no.
Well, it's just getting more comfortable for most patients don't want to wear them during the day. But basically we just say 12 hours a day of wear, but most people, at that point, when we're going to wean them off, at that point we're just going to, wean them off to 12 hours, and so we just say night time. It's just easier.
Okay.
But if they prefer to wear them, during the day, fine. But they've got to then take them out to eat and clean their teeth and all that type of stuff.
Yes. Yeah.
So does that sort of make sense?
Yeah. No, that's good. Yeah.
So it's just trying to get you to think about all the problems and how do we resolve it? So, the classic is exactly what you said, that upper right lateral, okay? And what we should have done, you got to remember, when you first started this case, you didn't, I'm just trying to, I don't know how to move. I don't know how to move on mouse.
Oh, you have to click on because
here
that's it. You got it.
Yeah. So when you first started this case, you'd only just done Smilefast. So it's a bit hard for me to explain to you about bracket talks and all this other stuff. This is all a transition that's happening. Okay?
Yeah.
But once we do the OrthoED program, we go through all the diagnosis. There will be a risk management. Okay. And what's the risk? The risk will be getting the torque of that upper right lateral. We would have been planning for that from day one.
Yeah. So when I swap the brackets, I still stay on my 20 square.
Yeah, well, provided it'll be hard to get in day one, okay, but if you can, that would be the ideal. And you will need to ligature tie them.
Yes.
Okay. Yeah. And when you're looking at torque, with this bracket system, you have to ligature tie it because the upper right lateral is the one that you want to torque. So you don't only just tie that one in, you've got to tie the brackets on either side.
Okay.
Because otherwise the wire starts to twist in these brackets and counteracts the torque that you want.
Yeah. Okay.
So always, if there's a specific tooth that you want to be torquing, then make sure you tie that one in with the ligature and the ones and the adjacent teeth.
Okay. Yeah. I'll remember that for future.
Yeah. Okay.
Yes.
Perfect. Beck, that went for 50 minutes. So I hope that gave you more insight into that case.
Yeah, that was great. Thank you so much for your time.
Pleasure. Are you going away over Christmas at all?
Yeah, I'll be gone. I'm actually leaving tonight, actually. So I'm originally from Taiwan, so I'm going back to visit my aunts and uncles there, and then I'll come back in June. I'm actually visiting a family friend who has an orthodontic surgery in Taipei.
Oh, fantastic.
So I'm going there to see what she does, about 4 or 5 days there.
Oh, fantastic. We'll enjoy.
Yes.
I'd love to meet you because we're hopefully going to introduce some orthodontics over in China next year in Shanghai.
Oh, okay. Yeah.
So that'll be great.
You go.
We'll have a fantastic Christmas and a great New Year, and to everybody else, a wonderful Christmas.
You too.
And a safe, and let's have the best 2019 that we could all have.
Yes, I'm sure it will be a very good 2019, Jeff. Thank you, and Merry Christmas to you and Robin.
Thanks a lot, Beck. We'll see you soon. See you guys. Thanks very much.
Yeah. All right.
Bye.